I've been on the Green Mountain Care Board now for almost 2 years. I think when I threw my hat in the ring to get the job, I asked a lot of people about what the Green Mountain Care Board was, and I don't think anybody actually really knew. And so I thought maybe we'd just take a minute to say the Green Mountain Care Board is a independent regulatory body. There's 5 of us. There's a chair and 4 board members. We're appointed by the governor and confirmed by the Senate, and we have some primary duties of regulating hospital budgets, regulating commercial insurance rates. We can modify them or approve them or deny them. Accountable care organizations, and we do some IT stuff, and then we are very involved with health policy initiatives in the state. We have Brendan Krause here from the Agency of Human Services, who's our new Director of Healthcare Reform, and we're actually really excited that Brendan's here and his interesting and broad background and perspective to bring to that. So that's what the Care Board does. We have a lot of public meetings. We're very focused on being public and transparent. And so, and in those meetings, we always have time for public comment, and we appreciate as much public comment as we can get on any topic that we're dealing with. And we also have an ability to write public comments off our website, and we get, over the last several weeks with these meetings, we get a lot of them, and we read all of them, and really they're quite informative and helpful. So we're here today because the legislature passed Act 167, and there's a part of that act which included a community engagement component to work on developing, and I'm gonna, hopefully I get this right, but basically a hospital sustainability approach for the state. So healthcare sustainability, hospital sustainability, we've had some challenges with hospital finance over the last several years. Bruce will talk a lot more about this. And so that was the hope of this, and and through that act and through that allocation of funds, we were able to hire a consulting firm, and we were very lucky to get Oliver Wyman with Bruce Hamry working as the lead person on this, and has gone, I think, from my view, way above and beyond anyone's expectations of the engagement and the time that he's put into this, the listening. He has been willing, and not just willing, but excited to engage with anybody who he could learn from more about how healthcare is delivered in Vermont. The things that I just want to highlight real quickly are that we are really worried about affordability of healthcare, access to healthcare, and sustainability of our healthcare delivery system. So affordability, commercial insurance rates are high and rising, and this is a national problem, but we have a uniquely challenging problem in Vermont. People feel that in premiums, people feel that in co-pays. I think anybody who pays property taxes feels it in property taxes this year. Healthcare costs are rising, and insurance is the mechanism by which we pay to pay for healthcare. Access challenges have been somewhat regional through the state. Primary care access has been really challenging in a lot of areas. Specialty access has been really challenging in a lot of areas. Hard to get a primary care provider. If you get a primary care provider, hard to get in to see them. You want to call them for an urgent visit, it's nearly impossible for a lot of places. I'm not saying that's what the Bennington experience is in this region, but that is, I mean, I work as an emergency physician. That's what my patients tell me. That's what I've experienced, so I think we're there. Another component of access, which we may not think quite as much about on a day-to-day basis, is that a lot of patients are boarding in emergency departments because there's not inpatient beds for patients to get to, and I think of that as an access problem. And that's really because, not entirely, but to a large degree, is there's not places for patients to go from the hospital to a long-term care facility or a post-acute care facility. And that's because there's not places for patients to get out of those facilities, or maybe we don't have enough of those. That's a complicated analysis that I'm not expert in, but there's a downstream problem. So that's all related to the concept of access, and Bruce will speak a lot about this. And then sustainability. Our hospitals' costs are rising faster than I think our perceived ability to pay for the health care that we get. They're rising faster than general inflation. They're rising faster than wages. So we're really worried about the sustainability of our delivery system when costs are outpacing our ability to afford them. So thank you for my time. I really want to get to Bruce, and then really the conversation afterwards. But before that, I want to introduce Brendan Krause, who's here from the Agency of Human Services. He's our new Director of Healthcare Reform. He'll tell you the number of weeks.
Yes.
And like I said, we're really excited he's here.
Thank you, Dr. Merman. Hi, Brendan Krause. 3.5 weeks, so I think I've got maybe another half a week of calling myself new. I think after that, I'm fair game. So thank you so much for having me and for coming tonight. I'd like to say thank you to Representative Morsi and any other legislators that are in the crowd that I didn't get to meet. Oh, I'll meet you after, I hope. I'd like to also just thank our colleagues at the Green Mountain Care Board who've done an enormous amount of work. I think this is the 10th or something like that. I'm not sure of these around the state, and it's a huge amount of work. Obviously, Dr. Hamry and his team at Oliver Wyman as well. I also, I'm going to keep my remarks very brief because, as you're about to see, there's an incredible amount of knowledge, and it's rather sobering, but it also presents the opportunity to make changes. I would just like to put this in context and sort of let you know what next steps from our perspective are, which is that we will take all of this information. It's unique to the communities that you've all participated, and the analysis has taken into account the local needs and the local nuance. But we will work with colleagues in the Care Board to take the recommendations that you have all commented on and that have been presented, and to analyze those so that we know a little bit more. How much would they cost? What would the impact be? And then begin to prioritize those and come back to the communities and get their perspective on that as well. And then the last thing I'd like to say is just, to put this in context, this is an incredibly important body of work, and our hospitals and our delivery system is incredibly important to all of us. But it's in context of other work that will be done. So in addition to this work, we will also be looking at how we can continue to support and strengthen primary care, and how we can address health inequalities and the social determinants of health, and the workforce issues that make all of this more challenging when we don't have the staff that we need, and access in general. So look forward to the evening and the conversation and to your comments and questions. Thank you. Sorry, I'm not very good at the handoff. Over to Kathy Fisher, who we're lucky to have this evening. She's the chair of the Green Mountain Care Board.
I'm actually the chair of Southwest Vermont Medical Center, but thank you for that. So really, the first thing I want to say is thank you to the Green Mountain Care Board for putting this together, for hosting this meeting, initiating this process. It's very important. And thanks to the team at Oliver Wyman for their very diligent work and listening to our views and the views of those in the community. And thank you, most importantly, to all of you for being here, because this is really important, and it's all about our community. So we are looking forward to hearing your views and your comments tonight, and answering any questions that we can. Just to give you a little bit of background on SVMC, it's a nonprofit hospital. It has a proud 100-year history of providing exceptional care and comfort to people in the communities. And then this Act 160 process focuses on Vermont healthcare, as it should, but we also serve northern Berkshire County, Massachusetts, as well as many communities in eastern New York State. The most important thing to know is that last summer, we became the 6th member hospital of the Dartmouth Health System. So we are now a part of the Dartmouth Health family, which we think is very important in that it gives us the ability to be part of an academic medical center and all the benefits that brings in terms of the caliber and quality of our doctors and the innovative thinking and technology and everything that comes along with it. We serve 75,000 people a year, and we're the largest employer in this region of Vermont. Now, as a nationally ranked and magnet-recognized rural healthcare system, SVMC has been working quite diligently prior to Act 167 to address many of the issues that are going to be covered in this report today, because we fully agree that we must continue to evolve in order to serve the patients of today and tomorrow at the level they deserve. So later on tonight, you're going to hear from our CEO, Tom D. He's going to share more about how we've been actively addressing the areas of concern and the priorities that are presented in this report. Because in many ways, this process has actually strengthened our resolve to move forward on many of the initiatives we've been working on for quite a few years now, in order to address the problems that we see in the system. So with that as a very brief intro, and again, we'll talk more later, I'd like to now turn the floor over to Dr. Bruce Hammery for tonight's presentation. Dr. Hammery is a partner and chief medical officer in Oliver Wyman's Health and Life Sciences practice. So Dr. Hammery, over to you.
Thank you very much. Well, good evening, and thank you very much for coming. We have a lot to talk about tonight. Congratulations, Mr. D. A notable achievement. So thank you for coming. Hopefully a rain-free evening. We seem to have had rain following us around the state. So why are we here tonight? Well, we're here to report back to you, the folks in the Bennington community, on our efforts to fulfill the mandates in Vermont Act 167. These are to conduct a data-driven, patient-focused, community-inclusive effort to assist Vermont's hospitals to reduce inefficiencies, lower or constrain cost growth, improve population health outcomes, reduce health inequities, and increase access to essential health services. So this project started with a focus on hospitals and exploded because, as you'll see, hospitals don't control who comes to them or where they go. And that creates all sorts of backup problems, as Dr. Merman explained, and we'll go through. So we've really taken a broad look at all the things that are being done in Vermont, or at least as many as we could identify, around the state to deliver health care people to Vermonters. My name is Bruce Hammery. I'm a physician with over 50 years of experience in practicing and teaching medicine in hospital and health system administration and in healthcare consulting. My colleague in this effort is Ms. Elizabeth Sutherland, a partner in the firm of West Monroe and an expert in health inequities. We've been ably assisted by Ms. Irene Way, our engagement manager, who's here, and by Ms. Melissa Kowalski, our senior consultant. We began this journey to examine the health system and hospitals in Vermont 11 months ago. Actually, now, a year ago, because we started August 1st last year. We have spoken with and listened to over 2,000 Vermonters from all 14 hospital service areas across the state. And I've personally visited every one of the hospitals and gotten a look around and to know very little about the area, but I can tell you what the roads are like in January and February. So we've also been greatly assisted in this journey by the staff of the Green Mountain Care Board, Ms. Marissa Melamed, Ms. Harley Watson, and many others. We have been helped by many leaders and staff throughout the Agency of Human Services and by Mr. Mike Fisher and his staff at the Office of the Healthcare Advocate. Mr. Mike Del Treco and his staff at the Vermont Association of Hospitals and Health Systems has also been especially helpful. Another consulting firm, Mathematica, and a team led by Dr. Arkadipta Ghosh has performed many of the data analyses we have used to develop options for changes in healthcare delivery. These have been presented to each hospital and its board. These options were then amended based on our conversations with the hospital leadership and its board. So why are we here today? We want to accomplish 4 things. 1, to report what you and other Vermonters have told us about your lived experience with healthcare. 2, to explain the problems facing your hospital, your community, and the state as a whole. As I noted, most of these are beyond the control of the hospital. We will show you what some of the impacts might be on your community and on the Vermont health system. 3, we want to share at a high level what some options are that could be used to address the current and future projected needs. These will apply to many hospital communities, but not necessarily to you. Fourth, and most importantly, we want to set the stage for your active participation as a citizen and a community to transform healthcare in Vermont. This process, as was noted, will be led by the Agency of Human Services and supported by the Green Mountain Care Board. This will be the next step in fulfilling the mandates of Act 167. These quotes represent some of what you told us in our electronic meeting in October. Quality of care is not the issue, but some things feel discriminatory for people who don't speak English as a first language. There is no interoperability of the EMR systems between the cancer center and the hospital system. I expect as Epic gets installed, that'll get solved. It's hard finding a primary care provider, which puts pressure on EMS and Southwestern Vermont Medical Center. Gender affirming and reproductive health access is an issue. There needs to be greater availability. Ongoing training at all levels of staff and health providers is needed surrounding stigma-free language and sensitivities, LGBTQ plus care, et cetera. And again, it's hard finding a primary care provider. So these are comments from around the state, and they're very similar. There are some other things. Lack of housing is a problem. Isn't enough transportation to other hospitals. When I go to the urgent care center, I may not see a provider because of shortages. Individuals, many don't go to care because the premiums and out-of-pockets are too high, and so forth. So a number of issues: housing, transportation, sensitivity to ethnic or other identity needs, language, and so forth. So let's set the background for your current experiences. As noted above, all Vermont communities are facing significant challenges to healthcare access, equity, and affordability. The access and equity challenges are shown in part on the left, the affordability challenges on the right. Note the difficulties in getting timely appointments for doctors and for surgery. So we hear stories around the state of 6 to 18 months to find a primary care doctor, 3, 4, 5 months to actually have an appointment that you're able to make, people waiting for eye surgery sometimes for a year. Transportation is an issue. I think Dr. Merman mentioned a little of this, but what we hear from most of the ER docs around the state is that if they have a patient that they can't admit to their local hospital, either because it's full or doesn't have the service, they may spend 4 to 6 hours calling up to 19 other hospitals to find a bed for the patient. So for that time, patient's sitting in the emergency room. After that, they have to call a number of EMS services. There are 76 in the state, and they may call as many as 30 to find an ambulance company to take the patient from hospital A to hospital B. So now you're about 10 hours, and for some of these things, an hour makes a difference. So it's not just transportation from the hospital to another hospital, but it's also how do you get the patient, as Dr. Merman said, from their home to the emergency room and back, or to the urgent care and back, or to the doctor's office and back if it's a urgent or same-day appointment, when you can get that. So transportation in a number of ways. And that leads to long waits in the emergency room. On the affordability front, there have been major increases in both health insurance premiums and out-of-pocket expenses, making the use of health care out of financial reach, even for many with good insurance. And we'll talk a little more about that in a minute. But major changes are needed to reduce these rates of increase. Vermont hospitals and many others in the U.S. are facing significant operational and financial challenges. These include the inability to recruit staff, whether that is due to national shortages of physicians, nurses, or other professionals, or to a lack of affordable housing in Vermont when they can be identified. So again, I've talked to a lot of hospital folks and actually heard from one last night that they've been able to hire people to, get a contract, extend an offer, have it accepted, and people will come to work and be here 3 months, 4 months, live in a hotel the whole time, and leave because they can't find a house they can afford. I will tell you this is a problem in other parts of the world, of the country as well. I served on a board in Bozeman, Montana, and we had the same issue. Housing prices went up threefold in 5 years. But it's a big issue here, not only for people you're trying to hire, but also for the unhoused, the people living in Vermont who don't have a place to go. A major issue affecting small communities is the number of doctors in a specialty that must be recruited to provide an acceptable call schedule. A call schedule is the number of nights in a week somebody needs to answer the telephone or go to the emergency room to take care of somebody. The community must also have enough patients to support that many doctors. 40 years ago, an acceptable call schedule was 1 night in 2. Now it is 1 night in every 4 or 5. So if you need a cardiologist, you really have to figure out how to hire generally at least 3, often 4, which means it needs a larger number of people to support that and the team. This presents recruiting difficulties across the U.S., not only for small hospitals, but also for larger ones like UVM and Dartmouth. Additionally, many hospitals are old and need to replace air conditioning, heating units, elevators, other equipment, and so forth. They have not been able to make the needed money from their patient revenues. In addition, some surgeries done at hospitals are done too infrequently for the staff to maintain an adequate proficiency. Many of these require not only expertise on the part of the surgeon, but also from the anesthesiologist, the operating room staff, and sometimes support from an ICU or other specialists. Supporting these teams with the staff and equipment necessary will likely require hospitals to combine some surgical and medical specialists in ways that support regional access without requiring people to travel to UVM, Dartmouth, Albany, or Boston. Many hospital resources are also consumed by people who do not need the services of an acute care hospital. These individuals may be waiting for transfer to a mental health facility or a chronic care facility. They may need a place to live or the services of a home health agency to be discharged from the hospital or from the emergency department. The hospital is not paid for these people as their care is, quote, no longer medically necessary. They also occupy beds and nursing time that could be used for other patients who do require care in an acute hospital setting. On the financial side, the costs of the people who work in hospitals and the drugs and supplies needed to care for patients are increasing at rates faster than those at which the hospital is paid. There have also been 4 unanticipated changes in federal policy within the past 6 weeks that will increase the cost of health care or potentially reduce access. None of these, I suspect, are in a hospital budget that has been submitted for review by the Green Mountain Care Board, just as an example of the sort of unpredictability of what comes down the road. First, an imposition of a tariff on all medical products produced in China. This will go from 0% this year to 7.5% next year to 25% in 2026. One of the presidential candidates has also proposed a tariff on everything not made in the U.S. Many of our drugs come from India. A lot of our medical equipment comes from Germany and France. So were tariffs to be put in across the board, we would have additional issues. These clearly increase the cost of supplies. Secondly, there's a new requirement to increase RN staffing in skilled nursing facilities. It's clearly needed. It's an important safety measure. But nurses are in short supply, so demand will magnify the shortage, if you will, and competition for wages. Third, a cut in Medicare payments to physicians has been proposed of 3.5%. So to the degree that the hospital supports physicians, there'll be a reduction in that income for the private practice folks. It clearly makes matters worse. Fourth, a cut of 7.5% in payments was announced for home health agencies. Now, this is a bit of a meat cleaver being used when maybe a scalpel should have been. So Congress identified that for-profit home health agencies were making a lot of money, and they said, okay, let's cut everything 7.5%. But unfortunately, they did not exempt the Visiting Nurse Association and the not-for-profit home nursing groups who are already struggling with an inability to pay nurses to keep them. And so that's likely to exacerbate that problem. Insurers also make it more difficult for providers and hospitals to be paid, sometimes by requiring pre-certification of testing, pre-authorization for procedures, or occasionally denying payment altogether. I would note the legislature has recently passed some legislation regarding pre-certification. In fiscal year 2023, 9 of the 14 hospitals in Vermont had negative operating margins. An operating margin is like the balance in your checking account. It reflects the income from patient services minus the expense of providing those services. If you include the 2 additional Vermont hospitals in the red in fiscal year 2022, 11 of the 14 hospitals in the state have recently had negative operating margins. This is a universal problem. This makes borrowing money expensive and difficult for the hospital, and makes the financial sustainability of the hospital problematic. I must note that all hospital directors and their staffs and the hospital group generally are working very hard to address these issues and to reduce their expenses. Not-for-profit Vermont health plans are also not making money. They are tightly regulated, and their premium increases are driven by the costs of care they pay to providers, hospitals, drug companies, and others. They are also required to maintain certain levels of reserves to ensure their ability to pay for the care you require, and these reserves are reaching levels that are alarmingly low. Every commercially insured Vermonter's cost for health care has increased markedly over the past 6 years. Shown on the left, between 2018 and 2022, the median increase in household income in Vermont was 22%. In the central panel, the Green Mountain Care Board approved hospital-requested increases in charges or rates of 38%. And on the extreme right, you see that the cost of a benchmark Blue Cross plan on the state exchange over that same period increased 108%. And if you look carefully at that part of the graph, you see in 2018, the cost in Massachusetts for that plan was $456, and in Vermont was $474. This year, the cost in Massachusetts is $468, and it's $948 in Vermont. And there's some other reasons for that. It's got to do with population and some other things as well. Okay. So how have we approached these issues? Well, we took the approach the doctor would do. We used interviews and data to make a diagnosis. We used tools and data to make a prognosis, a forecast of what the future might look like given certain assumptions, and we'll talk about those. We had developed and identified treatment options. Some were drastic and all may require substantial changes. You, as the patient and your community, get to make the choice of treatment together with your hospital board, other communities and hospitals, the Agency of Human Services, the Green Mountain Care Board, and others. We listened to you and to other communities. We took a history of your past and present illnesses, reviewed your symptoms, and so forth. The many people and groups we have interviewed are shown here. By the end of this week, we'll have spoken to roughly 2,100 people in the state. These people have included not only hospital leaders and boards, but also the many healthcare professionals who serve you. These have included dentists, physical therapists, mental health counselors, doctors, nurses, pharmacists, EMTs, home health agencies, nursing home administrators, and many others. We have spoken with many state agencies and departments as well as legislators. We've also met with a number of community and state organizations advocating for those suffering from health inequity and those with special needs, whether those are mental health needs, physical needs, or those having specific illnesses needing more specialized care. We have sought out groups with unique language, ethnic, and gender identity characteristics. We performed tests on your community. Mathematica did projections of total population in Bennington County. I want to call your attention to this carefully. What these projections show is that between 2020 and 2040, Bennington County will lose about 23% of its people. Now that ignores efforts that you have to bring people into the county, right? But that's a 24 or 23% reduction in total population. And what I want to call your attention to are there's upper two blue segments of the bar. So you see that the aged, the population between 65 and 74, is expected to go from roughly 13% in 2022 to 24% in 2040. And those are young people. The advanced elderly over 75, where I am, go from 9.3% to 13%. So what that says is in 2040, of those 30,000 people, 37% of them, or over 10,000, are going to be over 65. And people that old, whether they're just over 65 or they're really elderly, have different needs. So assisted living, better support for care at home and being able to age in place at home, memory care, socialization things, and a lot of other issues arise that are not, let's say, as common now. The other thing I want to call your attention to is that dark gray area, because this is very important. The number of working age people, those between 20 and 64 years of age, these are the folks that pay commercial insurance premiums, is expected to drop by almost half, 45%. Now, one of the issues with financing health care is that Medicare and Medicaid pay less than it costs to give that care to the hospital. So typically, Medicare's paying about 85% of cost, Medicaid somewhere around 65%. So that difference then gets made up by increased charges to commercial insurance. And if you think about this, what this says is you're going to have half as many people able to pay those premiums. And so if you need to generate the same number of dollars, the rates are really going to have to go higher. And that can't happen because people just won't, number one, they won't be able to afford insurance, so that money goes away totally. So this is a big pressure, along with the unanticipated things coming down the road and all that, to really get together, design a health system that works and can provide care in different places at an affordable level. Okay. So we did a physical exam to look at the systems of care, the least expensive places to receive care and to prevent the need for more advanced and expensive types and sites of care are at the top. Houses, group homes, mental health treatment, substance use treatment, and so forth. Enhanced capabilities and staff for primary caregivers, mental health and substance use disorder treatment is needed. The ability of not only primary care, but also urgent care and perhaps ambulatory surgery. As depicted, when these things are not readily available, people seek care in the emergency department, sometimes with an advanced form of illness needing hospitalization. If the illness is too far advanced or the community hospital is full, they may require transfer to a larger, distant medical center. The result is an inconvenience for the patient and her family, together with a bigger bill for the care. Using all this information, analysis, reports from prior state commissions, consultant reports, and so forth, we then constructed a financial prognosis or forecast. This makes certain assumptions, which we have tested with a number of folks, and I would note not everybody agrees with the exact numbers. Shown on the left here are increases in charges requested by Southwestern Vermont Medical Center and the rates approved by the Green Mountain Care Board. So you see over the 5-year period, 2018 to 2022, the hospital requested about 4.1% and was granted a 3.4% increase. More recently, requested a little more, an average of about 8%, and a little over 6% was approved. The graph to the right shows, if you look at that gray bar in the middle, to the left of that is past performance. That's the 5 years prior. The gray represents the base year we chose to do a projection from. And we chose that because it hopefully allowed time for the effects of COVID to wash out, volume and federal money and all that. And what we then did was we capped price increases or income for the hospital at 3.5%. This is the current cap on revenue set by the Green Mountain Care Board in its effort to slow the rise in healthcare expenses. In healthcare costs, rather. Estimates of the ongoing increases in hospital expense nationally range from 5 to almost 8%. My personal bet was 7%. There's a study out from PricewaterhouseCoopers 2 weeks ago that said they expect increases next year to be 8%. When we talked to hospital executives in the state, some told us they plan to control their cost increases to 5%. So that's the assumption we show here. So revenue, 3.5%, cost growth, 5%. And so no surprise, things don't go well. Costs go up faster than revenue. We also did projections using a 7 to 8% increase in expenses, and all of this was shared and discussed with the hospital and its board. Every hospital in the state shows these trends. There's only one with this 5% rate of increase that still retains a positive operating margin of about 1%, which is still not enough. If you take this to a 7% rise, some of the hospitals are minus 17% in 2028. So, really bad prognosis, and the reason to say let's fix the way things get done so that we can help people stay more healthy, or at least avoid the severe illnesses and be able to deliver more care when possible out of the hospital. This slide shows the increases in total hospital revenue approved by the Green Mountain Care Board over the past 10 years. The numbers at the bottom indicate that virtually 100% of all the dollars requested were approved. Of course, not every hospital had all its requests approved each year. And the reason that's the case is if you look at the small numbers to the tops of those blue bars, those are in billions of dollars. So 2013, $2.1 billion all in for revenue for hospitals. 2024, $3.6 billion. So within that money, a 1% unapproval is, a couple $100 million, which means the hospitals are still not getting what they want, but everything they want, but it's still a lot. And that cost increase over that 11-year period is about 74%. Next slide. So, as I said, the commercial insurance folk aren't making money either. Now, Vermont has only not-for-profit health plans. You do not have United. You do not have Aetna. You do not have these people that you read about that are, getting a profit of $15 billion in the first quarter of the year. This is Vermont Blue. And you note that in the last 6 years, they've lost money 5 out of the 6 years. And this means that what they are doing to support your health care payments is they are drawing down their statutory reserves. The Office of Financial Regulation in the state mandates that they have enough money in investments or in the bank so that they can pull that and pay bills when the premiums don't make it possible. I was on the board of Mass Blue for a while, and my hair would be whiter than it is now if I were looking at these numbers. This is not good. And you probably saw some of this a week or so ago in one of the Vermont newspapers. So, not much more money coming, okay? None from the insurers. Premiums pretty high for y'all. Fed's controlling expense on both Medicare and Medicaid. Medicare, I think, just proposed an increase in hospital rates of 2.6% for next year, which will not keep up with inflation. So, money not coming, staff in short supply. What do? You use what you got, redesign it, reallocate some things. Total budget for healthcare in the state of Vermont in 2020 was $6.4 billion. And if one just figures 10% of that can be identified, and I think that's very possible, and reallocated, then a number of the issues that are driving healthcare costs can be addressed. But it needs to be done thoughtfully and done. Okay, so what do hospitals do about this? Well, there are 3 things you learn in hospital administrator school. And the same 3 things we as consultants go out and teach people. One is you increase your billing. You increase the rates to commercial payers. You get a mechanism that's more efficient at collecting money. The second thing you do is try to cut your costs or your expenses. Staff is one of the major drivers. Staff accounts for about 65% or so of most hospitals' costs, and supplies and drugs make up another significant part. Small hospitals often do not have the ability to cut. So if you think about an emergency room in a small hospital, you have one doc, one or two nurses, a couple of MAs, and an on-call lab tech and an on-call radiology tech. So whether you see 5 patients or 35, you've got that same number of folks. And unless you close that emergency room, you've got that same number of folk. Okay? So some of this relates to size. If you're running, 40 emergency room bays like UVM does, if your volume really drops, then yes, you can lay some staff off or send them to work somewhere else. But the small hospitals often do not have that ability. So the other thing you can do is increase services that you get paid for, like orthopedics or certain heart things. When that fails, sometimes the last resort is to stop doing things that don't cover their costs, and those are usually pediatrics and obstetrics. So we'll occasionally, or perhaps not so occasionally, read about a hospital which is closing its OB services, and that's the last-ditch measure. Or you can ask somebody for money. You can ask the state, you can ask a donor agency, you can hope Elon Musk shows up with a couple of $2 billion to give you. But those are really your options. So as I said, hospitals can't do this themselves. And there are different approaches, I would say innovative, but they are in use in many areas around the country that can reduce costs and maintain and improve health services in the community. Doing this in Vermont will require concerted, sustained effort over time. And that's one of the reasons we're talking to you, because you guys get to help drive the process and make the decisions. So, where do we go from here? What can healthcare in Vermont look like? What is required? What things are already underway that could be built upon or enhanced? What does charting a path forward look like? Well, first, recognize the current situation and the adverse headwinds you are facing. The Marines would term this adapt. Second, change what you can and build on current efforts to change the way healthcare is delivered in your community. The Marines would call this survive. Next, design and implement ways to improve access, equity, and reduce the cost of healthcare for your community. The Marines would use the term overcome for this. Done in the right way, these changes can ensure that the redesigned services have a stable financial and operational future. The time to act is now. Abraham Lincoln said, "The most reliable way to predict the future is to create it." The new system you will design with the hospital leadership board and others will need to address both your current needs and those of your community in the near future. Shown here is the information, here you are. Shown here is the information from your most recent community health needs assessment done by Southwestern Vermont Medical Center and your community. And the mission of the hospital, of course, on the left. And then the needs, mental health, healthy behaviors and primary prevention, accessibility of care, and substance use prevention, reduction, harm reduction, treatment, recovery. So, well aligned with comments and other things from around the state. And based on that, here are a number of things that are being done. So first, as your board chair noted, joining the Dartmouth system is creating opportunities to expand a number of services in the community, cardiac services, vascular, orthopedics, oncology, and so forth, to keep care close to home. Inpatient units are growing their capability for alcohol detox. Certainly the hospital is well recognized as a magnet system, which helps greatly with nurses, not just with patients. They are expanding mental health access and have submitted plans, and I think doing fundraising, right? Okay, so a plug, give money. This is a valuable effort. They coordinate with a community care team for people in the community who need additional support, provide free and subsidized care, and are in the planning stages for a family medicine residency program, which is a phenomenal achievement and certainly a much needed approach to healthcare workforce shortages. So at a state level, generally in these 5 broad areas, there are needs. And they fall into these areas: the need for updated and modern information technology in offices, hospitals, homes, and other places where people receive care. Providing housing, as I noted, for both for Vermonters and for others moving into the state. Some in Vermont have no house. Others are living in houses without water, electricity, or heat. In my view, this is arguably the most urgent need Vermont has, not only to address inequity, but also to provide a safe place for people to receive appropriate care outside the hospital. Adequate housing, whether in a single dwelling, mixed income housing, group housing for those with certain needs, or assisted living facilities, is needed to reduce the crowding in hospital emergency rooms and the number of people staying in hospitals and mental health facilities because they have no place to go. Transportation for people to and from medical care and so forth, we've talked about. The emergency medical services, which are largely staffed by volunteers, should be combined, linked tightly to the hospitals, and made into a full-time professional workforce. This would create additional jobs in the community and allow the provision of patient transport to and between facilities using vehicles other than a mobile ICU when appropriate. In the planning process to be described, hospitals and communities will need to design a system in which there are regional referral centers, each containing an area with a sufficient population to support the physicians, staff, equipment, and other services needed to provide high-quality, efficient care for specific diseases or conditions. Work we have done and shared with many hospitals suggests there is and will be sufficient need that some of these centers could be supported so that people would not have to travel to UVM, Dartmouth, Albany, or Boston. In the system to be developed, all providers, primary care, specialists, dentists, EMT services, hospitals, social care providers, and so forth should have their payments linked to common goals such as access, quality, efficiency, use of appropriate resources, and equity. Let me be clear about efficiency. This means doing the right thing at the right time, not forgetting to give a vaccine, and not ordering a more expensive test when another may be adequate and less expensive. As noted in the green, the goal is to provide the most appropriate and needed care in your home, in the community, or close by. So there are many potential options. This is a very short list. We have roughly 120 of these, and I have given 2 previous presentations to the Green Mountain Care Board, one on June 19th and the other, I think, July 9th. That have more detail and slides that you're free to look at. We have a short time tonight, and so I'm not going to really go into 2 hours on primary care or mental health or assisted living or that sort of thing. We can deal with them in questions, but just this is a short list. I want to note that each of these things is being done somewhere in the U.S. So telehealth the hospital uses, and many do around the state. It's expensive. It needs to be better paid for and supported. Remote monitoring. You can measure your arterial oxygen with this thing and follow your heart rate. When I trained in 1971, the only way you got an arterial oxygen was you put a needle in the radial artery, you drew blood, you sent it to the lab, and an hour later somebody told you how you should adjust the ventilator or how much oxygen you needed. So this stuff is available, and other things beside. They link with telephone or your internet wireless, and they do provide a way that you can monitor the progress of a patient's recovery at home. So when you tie that with other services, nurses or EMTs who are trained to work in the home, you have a system where a number, not everything, but a number of common things, pneumonia, infected leg, I mean, a lot of that kind of thing can be done at home. You don't have to be in the hospital. As a guy who used to run hospitals, it pains me to say that, but it's true. And more places, including rural places, are doing that. The limits to it are housing. Do you have electricity and water? And do you have some way to connect to the internet? We've talked rural outreach programs, mobile vans to take primary care or mammography or screening for osteoporosis. Hours, we've talked about a little. Monitoring of the hospitals in the state for available beds. The Department of Mental Health Services in the Agency of Human Services has this capability for mental health beds. So you can call one place and find out where there are beds. This capacity existed in part because of COVID for acute care beds, but that program ended in May. So the thought is it would simplify Dr. Merman's life if he had one number to call instead of 19. We talked about service line specialization. There is a group of hospitals that have gotten together in the state to form a collaborative to support all their back office stuff, the finance, the HR, the PR, the supplies, and all that. And certainly Southwestern Vermont has that capability through Dartmouth. The last is to really pay attention to people who need a lot of health care. And there's a group of folk in every state, roughly 31,000 in Vermont, who have such high needs for multiple conditions, mental health, physical disability, and whatever, that they receive payments from both Medicare and Medicaid for their care. This group are called dual eligibles. They account for about 14% of Medicare beneficiaries, but consume 30% of all Medicare dollars in the country and 32% of all Medicaid dollars in the country. So there is a real opportunity to improve the health of a specific group of identifiable people, improve their health, take better care of them, and reduce the costs. reduce the number of visits they make to the emergency room, and so forth and so on. There is a program in Vermont, but it's small, the SASH program, that deals with some of these folks. There are not others that I've been aware of. So, and there are other groups that one could identify, folks like me that have multiple illnesses, and you could predict something happening and you take care of them ahead of time. So there are ways to do that. Okay, so this slide shows the major steps in designing your future. The first step is to make the decision to change. I hope this presentation and our previous sharing of information has convinced you of this need and its urgency. In this process, you and many others can choose among many options that we've presented here and elsewhere, and additional ones in the final report, and can construct some of your own. These options will then need to be examined for their impact on the community and for their financial stability. Planning sessions and budgets to support the final options will need to be made and the plans implemented. The Agency of Human Services will lead the process to gather the communities, providers, hospitals, and others desiring to plan their future, and will assist you in choosing among options to help to evaluate the effects of those and then help to implement the changes. The Agency of Human Services and its many components have numerous services available and are at various levels in testing and implementing others. Many, but not all, are listed here. Time does not permit an exhaustive review of this, and I discussed this June 19th. I would call your attention to the large efforts directed to mental health and substance abuse support and to elderly care support. Major efforts are also underway to improve the infrastructure for transmitting medical data and to streamline the licensure processes needed to get new healthcare professionals into Vermont and to allow them to practice. The Green Mountain Care Board has also had many efforts underway, as shown here. This project on Act 167 is the product of several years of effort on the part of the Green Mountain Care Board and the Agency of Human Services to set this project up that we've been trying to help achieve. The legislature has also been working to address a number of these issues. Okay, so where do you go next? How do you get involved? Well, you can attend community meetings and planning sessions, monitor the websites of the Green Mountain Care Board and the relevant units of the Agency of Human Services for updates and opportunities to comment, and provide feedback on their plans and activities. You can support the administrators of Southwestern Vermont Medical Center and its board in making what may be difficult or painful choices. You can speak with your legislators and the appropriate state agencies to express the need for making the laws and funding needed to put your changes in place. Change will not happen by itself. Designing and implementing an improved sustainable health delivery system will require the active participation and engagement of everyone in this room, of other hospitals and communities, and of the state of Vermont. As shown by this photo of an Amish community raising a barn in Lancaster County, working together, much can be accomplished. You have many more tools available to you than the farmers in this picture do. This is all hand work, occasionally with a horse pulling on a rope. Broad changes in custom and practice are also required across the state. What affects one community affects many others. An unplanned, unanticipated disaster in one community, whether a flood, a pandemic, or an unanticipated hospital closing, has impacts through Vermont. As I discussed a short time ago, The financial projections for many hospitals in the state show a diminishing financial stability over the next 3 to 5 years. Therefore, your time horizon or runway to design and to begin to implement needed changes is short. The airplane runway on the left is 2 miles long, 10,000 feet. The runway on the right is on top of a mountain in Bhutan and is 900 feet long, with a cliff at one end and an airplane hangar at the other. I've been to that airport. I did not fly in. There are 8 pilots in the world qualified to fly into that airport, and only when it's clear, like this. So your runway is longer than 900 feet, but it's not 10,000 feet. I'll give you a personal example. I live in a town in the central Massachusetts that has about 3,000 people. My town argued for 5 years over whether to allow fiber optic internet to come to town. Okay? Now, you don't have 5 years to argue, right? So you have a process. You're fortunate. Secretary Samuelson has met with the hospital leaders a couple weeks ago, I guess, starting the process, and this will continue. Our final step in the next several weeks is to give, sometime this fall, to give a final report to the Green Mountain Care Board. And then using that and a lot of other things, the planning process will commence, and then implementation will happen. But it's critical that that be done in a thoughtful but timely way. Time is not your friend. And there will be, I think, some major changes in a number of communities that will need to be made. So, thank you. Mr. D, the microphone is yours. I'll give it that. We're going to give you that one? Okay.
Thank you, Dr. Hammery. And good evening. I'm Tom Deeb. I'm the CEO of Southwestern Vermont Medical Center, and I want to thank you for being here tonight, and also thank Kathy Fisher for her introductory comments. And also, we have a number of board members from Southwestern Vermont Medical Center here. I want to thank them. And just so people are aware, the board members are all volunteer, all non-paid, and spend many, many, many hours dealing with issues that Dr. Hammery has raised here. And I do want to thank Bruce and the team from Oliver Wyman. I think they did a very good job. I mean, directionally, I think we're in agreement. We're never always in 100% agreement, because always these reports have lots of assumptions, and sometimes assumptions can be debated back and forth. But in terms of the key issues that have been raised, the challenges, we are in agreements, and certainly the financial challenges are real. So I just want to make a couple of comments, and I want to encourage the questions. But what I want to highlight is one of our key strategies is to keep health care in Vermont for Vermonters. Try to encourage and create programs and services that allow Vermonters to be cared for close to home. And we can show, and also the Green Mountain Care Board just shared some data with us in the last couple of weeks, that shows that even though our health care costs are too high, and we'll be the first one to admit that, the lowest health care costs of hospitals of our size in the state, as well as in the Albany region. The Green Mountain Care Board's numbers did not include Albany. Our numbers do. We've delved into all of the areas, and within a 75-mile radius, we have the lowest healthcare costs. So if we're able to create programs and services that allow Vermonters to stay locally here, That will help drive down healthcare costs. Now, we're not going to, let's be real, as Dr. Hamre said, we're all getting older. Our population in Bennington is undeniable, the trend it's going. So the most of what we can hope for is trying to bend that healthcare cost curve. We're not going to eliminate it. We're not going to really reduce it, not when you have those type of numbers we're looking at. But we think with our relationship with Dartmouth-Hitchcock, we have a much better opportunity to help control those costs. And there's a key strategy here is for us to become a regional referral hospital, focusing on services that right now many people are leaving the area for. Cardiac services, oncologic services, areas, mental health services. And, we're never going to become an academic center. We have to realize what we are and what we're not. But we can become a very strong secondary provider and allow us to start to treat some of the patients that right now have to go to Albany, have to go to Dartmouth, have to go to UVM for their care. We think we can provide a certain amount of that. And it's about, it's about 4,000 or 5,000 patients a year that leave. I put it into dollars and cents. It's about $50 million a year leave our community. People who live here who leave for their health care services. So we're working hard. We're working hard with Dartmouth to see what services can we create. And over the next 2 or 3 years, we're going to focus a major effort on cardiovascular services, on oncologic services, surgical subspecialties, and also start to move into a new direction for us, which is mental health and substance abuse services. The community has a need. We have not been filling that need. We think there's a role for us to do that in partnership with other providers like UCS, with the retreat, with Dartmouth. And I think if we can collaborate together, and I'm very optimistic we can. A provider like UCS is a great collaborator, and I think we can do things together that can help in those areas. So we will be changing how we provide services, the scale and type of services. The need for primary care is, universal. I know Dr. Dobson's here tonight, and he spends a great deal of his time working on the primary care challenges. And I know the Battenkill Family Health Center has the same issues. Many of the private practices have the same issues. Our movement towards working with Dartmouth to create a teaching program, a residency program, and I did this back in New York where I came from, and we were in upstate New York, an area not dissimilar than here, and we had one of the lowest, one of the highest levels of the need for primary care physicians. We created a residency program, and it took us about 15 years, but we had one of the highest concentrations of family practitioners after the program was up and running. Long-term strategy, a heavy lift, expensive, but something which I think is worthy of the community and ourselves in Dartmouth trying to make it happen. So again, a lot of very legitimate concerns are raised. We don't have that 2-mile runway, but we're on it already. We're not sitting back and waiting for things to happen. We're making things happen ourselves, and I think we can, with collaboration with the state, with Dartmouth, with other institutions, and other entities, agencies, I think we can make a headway. But this is a real challenge. I've been in healthcare now for 42 years, and it's never been tougher. So, and first being in a rural area, this is not southern Westchester where I came from. This is, rural Vermont, and things are much more challenging, especially on the provider recruitment side. But we applaud your efforts. We applaud your highlighting this. I think Mike Del Trecco is here for the Hospital Association. Mike's over there, and he is working with all the hospitals to have them try to embrace these reports and see how we can collaborate to address them. And clearly, healthcare costs is a big issue, and one of the major issues that we're focusing on right now is how to drive those healthcare costs down. So thank you.
So we have time for questions, comments, and yes, sir.
I noticed that in the presentation, I'd like to. I noticed in the presentation that the administrative costs of the entire healthcare system kind of got short shrift. And I'm not sure why. I'm curious as to whether when you started this, you went to every one of the hospitals and asked for a breakdown on their administrative costs, especially billing. Because at least nationally, I have no idea what it's like in Vermont, but nationally, you got things like the Duke Medical Center in North Carolina with 957 beds, employing 1,600 billing clerks, as opposed to the University of Toronto, which has 1,272 beds, a third more than Duke, and has 7 billing clerks. And I know that there's a similar problem in medical practices. The Commonwealth Fund, about 10 years ago or more, did a study and found that American medical practices spend 8 times as much time on billing issues as a Canadian practice. So I'm just curious as to how that fits into what you're trying to do here, because it doesn't look to me like there's any way that you can do much about those administrative costs, especially billing costs, unless you really change the healthcare system that we operate under. Your analysis is of the current system. I personally prefer single payer. I know that that's not everybody's cup of tea, but way back in 1991, the GAO issued a report to Congress which said, and I quote, "If the universal coverage and single payer features of the Canadian system were applied in the United States, the savings in administrative costs alone would be more than enough to finance insurance coverage for the millions of Americans who are currently uninsured. There would be enough left over to permit a reduction or possibly even the elimination of co-payments and deductibles." I think that's really all I have to say. It seems to me that even if you're successful in this, you're not going to be successful overall in the long term until we get down to what's really causing the costs to go up so high. Thank you.
Yep. Thank you for the comment. No question that administrative costs figure insignificantly, and there are ways to cut that. Just point out that single payer does not fix the operational problems that you also have. Right? You've got people that have perfectly good insurance that still can't get in to see a doctor. So there is an administrative cost, and there are measures that are being done and more that can be done to cut those. But that's not going to fix your access issues.
It's going to get to some of them.
It won't get any of your access issues fixed. What it will do is let the doc get rid of the 4 people he's got doing billing, right? But it's got to get them some more nurses and some med techs and some other folk.
In terms of the people who can't afford the premiums and can't afford the co-pays, this would help.
That would help, yes, agree. Not necessarily single payer, though, but cutting the administrative costs. Agree with you. So others, there was a comment. Sir, yes, sir. Yeah, please. I'm sorry for the need. We have a wire attached to this one, so.
First, thanks for your presentation. It's very good, and I'm a big supporter of SVMC and the things they're trying to do. One of the things you didn't mention that I expected to see was some need for a common medical record among the hospitals in Vermont.
Yeah.
And I get scared about not having that. The other comment I have is the part of our issue to me seems to be the baby boom from World War II going through and consuming services. Those 2 blue parts of your graph consume more services than the others. And I agree there's some high utilizers, but I think that's really what's behind this. And the secondary factor you didn't mention is the average age of Vermonters it's fairly high, I think within the top 5 of the country, and that drives some of the healthcare costs.
Oh, you're right, and I, like I said at the start, had to skip a lot, but the part of that you're talking about with a medical record that's transferable and you can access and is in this modern technology piece. The other thing that we did do, as you point out very correctly, people over the age of 65 have an average of 10 to 11 visits to a doctor a year. If you're between 3 and 64, it's about 3 a year. And only in that first 2 years of life does it hit about 7 a year. So that's a big issue. And one of the things we did do was to go area by area and use those kind of numbers to say how many primary care doctors and nurse practitioners do we think you're going to need in 5 years and 10 years. And we shared that. And there are a lot of other assumptions, but yes, thank you. I mean, there's a lot more here, and it's a lot more detailed than I'm able to present. Thank you. Other questions or comments, please?
Good evening, and thank you for my name is Jim Carroll, representative for Bennington. Thank you for the presentation. Congratulations, Tom. Legislatively, what can we do, and what do you see as the priorities that the Vermont legislature can do to accomplish and move towards the goals that you have outlined?
We have a long report coming to you shortly. Okay. There's a list, and no, I'm serious, sir. Really, you're right on the question. What we've been asked to do and are in the process of doing is formulating some options for each community because they have different needs. But then some at a state level that are overarching, and then some of the recommendations to the legislature for enabling legislation that would be needed to make some of these things possible. So that'll be coming to you.
Okay, great, because we have 2 legislators in the room, Seth Bongartz and Representative Morrissey, who have long experience in the state and know where the levers are and how to use those levers.
Okay. Thank you. Well, a couple of things with that opening. I think one, you've had a number of programs to improve housing facilities. One of the stumbling blocks to that sometimes is the length of time it takes to get through environmental regulations and zoning. And I've heard stories of 5 years to get that done, and that's way too long. I think the other, which was raised, is the availability of a system to interconnect the various electronic health records. There are at least 5 different ones that hospitals use. I've been given a number somewhere around 40 for the ones that the private practices use it. There is a program, Vital, which has been underway for several years to try to address that. There are a couple of things. The lady who runs that is very knowledgeable. I suspect she is underfunded and understaffed. And as some others have commented, that's a critical need, right? When somebody shows up to see Dr. Merman, he needs to know what illnesses they've had, what medicines they're on, and if at all possible, what their latest lab results are, so that he has something to compare to. That's not readily available. Now, it's been a number of years since that program was started, and there have been new technologies that have come out in the meantime. So it might benefit from a quick relook. Is there a different way to go at this? I think another thing, certainly, is that there are many, I think, pilot programs, I'd call them, around the state that are quite interesting in terms of, rapid response teams for mental health or community health nursing or whatever, but they are quite small. And many of them lack consistent funding. And so I think this is one of the issues that Mr. Krause and his team will be taking, is how do you identify those things that bring the most benefit and help get funding so that they are widespread. So it's not three places in the state that have them, but it's 15. And how do you regionalize that? Because the other thing that we learned, as part of this, somebody very new to Vermont, except for visiting a lot of your covered bridges, is that you have many different ways of organizing things, right? You've got 14 hospital HSAs and 6 different regions for mental health, but I may have the wrong one, and other things. And those might be able to be aligned so that when Tom's folks need to call somebody, or the care coordinator in the community needs to call somebody, she has one number. I was talking to somebody earlier who tries to coordinate care, actually 2, and they have their own personal list of who they call. So a database that would have that would be accessible. And I've seen other hospital systems do that, right? It takes a graduate student for a couple months. So there's some simple things like that, but I think the big issues will be funding for a period of time the work that Mr. Krause and the agency has to do. This is going to be a big project. Okay, this one's been a big project. It was supposed to take 6 months, it's taken 12. Okay, and that one's going to be bigger. So I really do think that appropriately funding this second phase of work is probably the highest priority, because it's what's needed to get the communities involved and the hospital people together to make some decisions about who's going to do what. I mean, Tom's fortunate. He's got a big enough group and belongs to a big enough organization that he's got those supports. But when you look at places like Springfield and Newport and others, they don't have those resources, and they're going to need people who can come in and help get those things together and give them the cover, because nobody wants to go to jail, to say, look, I'm better at doing this, why don't I do this? And you're better at doing that, why don't you do that? And that's, when I'm talking about things like regionalizing healthcare, that's sort of thing I'm talking about, okay? But I think, again, for me, the biggest issue, other than housing, is really getting adequate support for the folks who are going to have to actually get all this done, because they're going to need that for 2 or 3 years to really push this forward. I hope that's helped.
I have just a tangential question.
No, here or here. You don't have
Oh, you can use that one.
Just a tangential question with respect to treatment. I finished my last year of school at Oxford University in England, and there were some other students that I was there with who needed care. And what I learned, because I accompanied them to their visits to the doctor, is the medical system there is based upon outcomes, successful outcomes. And I wonder, Tom, is that something that is adopted or already in place here at Putnam? And there'll always be Putnam for me. But that model, and the outcome was tied to income for doctors. The better outcomes they had, the consequent raise in pay. And it also followed, there were longitudinal results that could be examined and conclusions drawn from by that program.
Primarily, in most areas in the country, that's not the model. The model will be primarily based on how many patients you're seeing, in terms of the volume of care versus outcome. So, that's really, certainly, Dr. Johnson can speak to that more, but, some organizations have done that, Jim, but it's really been few and far between. I'm not sure what Geisinger was doing.
No, we did that. I wrote a comp plan for that, and that's done. But to do it, there are a couple of things you have to have. One is you need to have a way to measure what that quality is. And you generally proceed from the available studies and data that say, look, doctor, if you control the blood sugar or the hemoglobin A1C to this level, then the number of heart attacks and strokes and all that drops. And so you set that as the measure, because you wait too long to measure that other. But yes, you can tie that to pay. But the other key to it is you offload a lot of that care, because the nurses and the diabetic educator and all those folks really do most of that work, right? And so that's where this idea of the patient-centered medical home and team care and all that comes in. And one of the issues, other than the lack of an overall medical record, now Dartmouth, of course, has one. And I used to go to Dartmouth and teach some of this with those guys, so they know how to do it. And UVM is got the capability. But so that electronic medical record's one piece. And then the other piece, which is not currently in place, there is an effort through the Vermont Health Plan and the ACO to pay the primary care physicians based on certain quality metrics. And those are relatively few, and they're still somewhat hard to measure in real time. So that electronic health record system would certainly help get there.
Hi, sorry. I just have a quick question. I'm wondering if you could address, as far as I understand, Vermont has been chosen to be a part of the AHEAD program to start in 2026. Clearly, we all understand that's increasing primary care, but the part about the reimbursement, how that could change for Medicare, Medicaid, can you just talk briefly about that? Because I don't know it very well.
Yeah, I actually can't.
Okay.
Number one, I'm really not involved in that, but I think more importantly, number two, the state is only getting into those discussions.
Okay.
Right, so there's not been, as best I understand.
So all of this that you're projecting does not take into account that the reimbursements could change significantly in 2 years in the state?
And that's the reason we only went 5 years out.
Okay.
Other than 5 years out, anything's a guess, a total guess. We didn't really know what payment system you all would be under.
Okay, thank you.
Thank you. Sorry I couldn't help. Any other comments or questions? Okay, we put you all to sleep. I'm sorry.
We could probably get the mic. We're trying to have the mic for closed captioning, so if anybody would like to, we could probably wiggle this mic.
I think it is picking up, so if you want to just take it from your seat.
Yeah, so
I'm just trying to.
let me just remind you that these slides are posted to the Green Mountain Care Board website. There is a section for comments. We look at those things every day, and we take them seriously. And we've actually been known to call people up and say, "What you mean? Let's talk about this." So please, if you have other comments you haven't been able to make, or you think about something tomorrow morning in the shower or Sunday afternoon while you're mowing the lawn, please put them in the website, because we're getting down the final path. We have one more meeting in St. Johnsbury and one statewide meeting Monday night, which I will also mention. If you have friends, family members, or somebody who wasn't able to be here, and they can certainly sign up. It'll be a statewide virtual meeting. Similar presentation, but the opportunity for comments and other things, and would encourage you to get the word out to your friends, neighbors, and others. So thank you all very, very much. Appreciate your taking time on such a lovely summer evening. And let's give Mr. D another round of applause. This is great.